Good morning, everybody. It's day 2 of conference, it's Liverpool, and it's question time. My name's Martin Marshall. I'm Vice Chair for External Affairs of the College and a GP in East London. And today is question time, and on the panel from the far end, I'd like to introduce Helen Stokes-Lampard, who might be familiar to two of you, Chair of College and a GP in Lichfield. Arvind Madan, who is Director of Primary Care in NHS England and a GP in London. Rubina Shah, who is Chair of our Patient and Carers Partnership Group within the College. Holly Hardy, who is a GP and educator from Bristol, and Roy Lilly, who's a commentator and policy analyst extraordinaire from the Twitter sphere, I think is the right place to put you. So you'll be very familiar with the format of question time. You're going to be invited to ask questions. There's microphones. I'd like you to come up, queue by all means, in order to ask your questions. When you ask your questions, please introduce yourself first of all. The questions, I'm absolutely confident will be professional and respectful. I'm also going to ask that they're as succinct and as brief as you can possibly make them. The only difference with the real question time is that these questions have not been prepared in any way. So we have a very courageous panel, and I'd like to thank them for that. So I'm going to kick off with one warm-up question as I wait for you to come up to the microphones, and please come up as and when you feel ready. A warm-up question for the panel, maybe an easy one, maybe a very difficult one. Will general practice look significantly different in 10 years' time from how it looks now? Rubina.
So for me, there are some things in general practice that won't change, and that is the care and compassion and the dignity and respect that we experience as patients and carers from our professional GPs. But there are some aspirations that we also want to see and hope to change, and that will be a fully funded GP general practice with a workforce that is capable and competent in an environment that is suitable both for GPs and for patients, so your mental health and your physical well-being is being catered for and looked after. And last but not least, and I'm sure there are more to this, that we have medical students who are queuing up to become general practitioners in the future, and that's because they know it's the best specialist area to be in, because you can have a relationship with patients and with carers in a proactive and pragmatic manner, but always in the context of caring and compassion.
Thank you. Arvind.
Well, I don't foresee a future in certainly the next decade where we won't still have the doctor-patient relationship at the heart of the interaction in general practice. And I think of all the things that may change around us, I don't think that's one that will, and I think that's one we need to aggressively protect in the future. But actually, I think we also need to be realistic about what the advances are in terms of technology, artificial intelligence, other remote-type ways of managing care that are likely to come along. I think genomics is potentially going to have significant impact. What we must protect within that is that personalized journey, whichever route is used. I have a fantasy that sometime in the future there will be a time when we can actually monitor good proportions of our patients flowing through the system, and that might occupy a third of our time with sort of an ability to monitor what's happening with them remotely, and about a third of our time will then be freed up for dealing with the patients face-to-face who have complex needs, and about a third of our time may be looking at actually what are we doing with data analytics and population care, and why are my asthmatics going to hospital more than the practice down the road. There's some interesting suggestions about what might be the future of the sort of biological bathroom in the sort of technology-rich home. What might biometrics be sending in through telemedicine so that patients can be monitored remotely, and actually we can, instead of churning thousands of patients through our surgeries every day with long-term conditions, we might be able to monitor some of that biometrics and intervene with some of those deteriorations rather than necessarily the way we do it now. I've heard suggestions about drones delivering ingredients of medication to our front doors. that fit into our fridges with a 3D printer in to create the right medication and tablet for that particular day in relation to it. So there's lots of really exciting suggestions being considered, but actually, as I say, at the heart, we need to maintain the doctor-patient relationship.
Holly.
Thanks, Martin. I would say plan for the worst, but hope for the best. That would be my motto. So plan for the worst would be planning for a purely salaried GP service, and hoping for the best would be that we can develop multi-professional team working whilst maintaining continuity of care for our patients.
Thank you. Roy.
Thank you. Good morning. I think GPs will be brokers of care and carry on very little face-to-face care. I think long-term conditions will be managed by call centres remotely. I think most GP practices will be owned by trusts, and nurses will practice in shops and supermarkets with the front line of care.
What can one say apart from ask Helen to respond?
Where's my round of applause? What happened? I'm not hearing it.
Helen.
Oh, Dave, good morning. Thanks, Roy. It's great coming last in a list like this. It won't surprise people who were here yesterday to know that I believe that the future of general practice is about person-centred care and Enid-shaped care. And if we were designing a health system right now, it would look different from what we've got. We haven't got that luxury of starting again, and actually a decade isn't very long. I'm old enough to know that the years flow past very quickly, and absolutely patients will be at the heart of what we do. I do agree with some of my colleagues in that GPs will be doing less of the immediate care. I think we will be very established as consultants who are conductors of the primary care orchestra of professionals. I think Arvin's right, the technology will play a far greater part in what we do, allowing us to consult in different and innovative ways, which is what our patients want, after all. It'll take a bit of a shock to the system to some of us to get used to that, but actually general practice is phenomenal at adapting to change, and we're usually the forerunners in embracing technology. So I have confidence we'll do it. I don't have the confidence that some of these, the genomics and the drones and all this will be that far advanced in 10 years. I think that's 20, 30 years down the line. But actually I do believe that we will still be absolutely as patient-centred, and cum scientia caritas, the college's motto of scientific knowledge applied with compassion, will be every bit as valid in a decade's time as it is today.
Thank you very much. Microphone 2.
Morning. My name's Julia Riley. I'm a GP on the Wirral and I'm a lecturer at Manchester Medical School. I'd like to ask the panel, noting that 80% of patient safety incidents in the NHS happen because of simple human factors, slips and trips. Why, as NHS leaders, are you slow to address this and to make practice safer? Patient safety is your strongest argument in general practice.
Thank you. Arvind.
So I think people will be aware that we had the unplanned admissions enhanced service until last year, and actually we stood that down because it was felt by many to be a disproportionately burdensome amount of work for the benefit gained. And we replaced that with the frailty index, which actually was something that we felt was more targeted and actually allowed a more permissive environment for us to shape the care of individuals. And going specifically to the question of slips and trips, a falls analysis is a key part of that, because the national clinical directors working in this field told us that that's a very specific thing that we can zoom in on that will start to make a difference alongside medicines use reviews and actually populating the enriched summary care record, so the ambulance on their way to Enid or whoever actually is well informed of what the person's desires are. So I think there is a slow shift towards giving us the autonomy we require to address safety issues that are specific to a particular patient's needs, but there's always more we can be doing.
Holly, as an educator, are we giving enough emphasis to patient safety in the way that we train doctors?
I think we probably give a lot of lip service to it. We recognise that it's important, but I think one of the constraining factors often is about trust and about being in an organisation where you feel able to say if things aren't going right, because the only way you can look for better solutions or better ways of doing things is if you can see what's actually going wrong, and then you can start to build on that in a constructive way. The other thing is about workload. So obviously we're all getting increasingly overworked, and this is when safety becomes more paramount. So I think we've got to build on those issues of trust.
Can I ask a question? Do you believe that safety is a top priority, more important than overdiagnosis or underdiagnosis or efficiency?
Yes, I do. I think it's the most important priority, and I think other things will follow if you regard it as such.
Okay, tremendous. Thank you very much. Let's take a question from number 4.
Thank you for having me. Welcome everyone to the Question Time. My name is Dr. Riyad Kabir. I'm a GP from London. I was listening to Dr. Shah saying a lot of people now, a lot of doctors are queuing up, a lot of students are queuing up to become GPs as a specialist. Again, Dr. Lampard was mentioning the word consultant. Sitting at a practice reading the letters, it doesn't really seem that way. When you read the letters, you're having consultants treat as secretaries, saying, follow up with GP to refer to this, that, and the other, which is practically next door to where their office is. Listening to people in the pub, they would say, I've been to my GP, they've been ... but my consultant was brilliant. In the public eye, GPs are not really looked at as specialists at all. They are GPs. Some of us think of us as generalists. There was a talk a few years ago, or sometime in recent times that I've heard, that this would be to bring it in the public eye, to GP status be up to a consultant or a specialist status. And there was talk about the register being shifted. Has there been any progress, or is there any change?
Helen, GPs are being treated like secretaries.
There are 3, great question. There are several elements to this one. So the first thing, let's be absolutely clear. We get CCT. We are consultants as general practitioners. We are consultants in general practice. That's what our CCT means. So yeah, absolutely. And do not let anybody dissuade you of that. And all of us have our part to play in helping change public attitudes, because it wasn't always so. It's only since the CCT has come in that is the case and is clarified as such. The GMC and the BMA are absolutely clear that we are consultants. It's just the terminology consultant general practitioner is not widely used. And yes, there is misunderstanding in the public, but we can all help change that. I don't want to be precious about it, but I do want to be very clear about it. The second issue about the single register is a different one, and we in the BMA have been working quite hard on this, and we've had some significant promise, and we've had letters from the GMC confirming that they will work towards this. One of the problems at the moment is actually there is no space on the legislative timetable to get the legislation changed to bring it to a unified register. There are some risks potentially in having one register, because then could a consultant who just call themselves a GP and change across. So there's some technical things to work through, but absolutely it's on the radar and it will happen. But you are a consultant. Every single post-CCT GP is a consultant, so no hesitation in that one. Perhaps we need to hold our heads up high and act like consultants. As far as the nonsense about stuff that we are sent from secondary care, some of it is a consequence of the contracting model and the way that hospitals have forced consultants to work and banned them from inter-referring. But there was a change to the hospital contract last year that the BMA negotiated very successfully, quite clearly stating this should not be the case. And there's been something just the last week that's gone out reconfirming this and improving this, because some CCGs have been very slow to implement. So all bad practice, bounce it back, very dignified, do what's right for the patient first, but then call it out when you're seeing bad practice. I certainly sent some very nice letters to my consultant colleagues, thanking them for asking me to do their work for them, doing the work because it's in the best interest of the patient, but referring them to the consultant contract nowadays.
Thank you. Rubina.
Yes, thank you for that question. So the latter part of my statement was aspirational. So I was trying to see the world as being positive rather than negative, and the aspiration would be that we would have medical students queuing up to go into general practice because that is considered to be a valued profession. Now, the narrative of general practice, the narrative of the GP story, is actually written by your good selves. So you need to talk it up a little bit more. And just going back to the earlier question from Julia around patient safety, I think general practice needs to catch up with patient safety. There's a lot of focus and a lot of attention within the acute sector, but actually patient safety needs to be a higher priority for general practice, because patients, when you see them, and the carers who accompany them, will want to know and want to feel that they are safe in your hands. It isn't a given judgment that they make. So we have to work at it. And many of the things that we've been discussing at this conference yesterday, and we've been discussing for a very long time, most patients and most carers, families, don't really know a lot about this debate. They don't know about models of care. They don't know about the struggles that general practice is having in terms of its workforce. They don't know always that you are tired because of being overworked. But do they care about you? Of course they do. Because they care passionately, and they're totally committed to general practice. But let's be clear, from a patient and carer's perspective, again going back to the patient safety focus, if we don't change the culture in general practice, if you don't have the learning when you are medical students and also when you are at postgraduate level, and if you then get it or you are prepared for it when you enter into the hospital setting, that's far too late. We need to promote our awareness, we need to protect our practice, and we need to consolidate together what it is to be, achieving your CCST, which is a fantastic moment. But the final thing I'd say is, when patients think about consultants, they do think of a higher order, but that's because of the narrative that hospital doctors have given to them. You need to pump up the pressure on your own narrative and make patients, not make them, but help them to understand that actually you are specialists, you are experts in what you do. It's your clinical knowledge that they seek. And with that expertise, they also give to you in partnership the lived experience that they are feeling and want to have assurance from you, but they can only get that if you feel valued yourself. But patients and carers, they do value you. Sorry.
So we should be writing our own narrative, and it should be a positive one, is what you're saying.
Yeah, absolutely.
Yes.
Thank you. Roy, your narrative in your opening statement wasn't entirely positive. What do you think?
I thought it was very positive. You asked me what was going to happen. It's all going down the loo. And I wanted to answer Julia Riley's question, but now we've moved on to, I can hardly keep up. This
Welcome to
very
general
early in
practice,
the
Roy.
morning, and I'm an elderly, frail gentleman. Listen, GPs are going through an identity crisis, aren't they, at the moment? I don't know really if you feel... I'm sorry you feel pissed off, Riyadh, because you look like a nice man to me, and I wish you were my doctor. But you've got to decide. I mean, look, we're getting 90% more, isn't it? They're more than 90% of our first contacts for less than 11% of the budget through primary care. I don't know where you sit in all this. I want you to be family practitioners. That's what I want you to be. And that's what I think you're best at. And that's what I think you should do. But it's drifting away. It's slipping away from you. I can't have a doctor anymore. I've got to have a practice, and I don't know anybody there anymore, and you're all being merged, amalgamated, federated. It's kind of changing, and you're letting it slip away. You can't be the local hospital and do the stuff that they do. All this business about saying, oh, we're going to move everything out of hospital and let the GPs do it. Firstly, you can't, and secondly, that's not really what you're there for. You make the most important contribution to healthcare. I mean, I travel a lot talking about the health service. I'm just back from Canada. And the thing they most admire, wherever I go, is primary care. And I think you've gone through a period where you're selling yourself short. No one wants to be a GP. Everybody's leaving. The pressures are horrible. You've built this kind of image about being a GP that if I was a young doctor, the last thing I would want to be is a GP. It sounds like a horrendous job. I'd much rather be in a hospital and, fiddle about with little tiny bits of people's bodies and be a specialist. What you do is much more important. You need to give yourself a good talking to, I think.
Microphone one.
Right, I'm Stephen Lawrence. I'm a clinical academic at Warwick Medical School and GP in Kent. And I'm proud to be a GP. I enjoy my job and I love doing it every day. To answer I practice in Kent, which is quite interesting because it has a contrast in terms of practice sizes. We have the largest number of smaller practices and single-handed practices in the country, but also we have one of the largest and fantastic flagship companies, rather than practices, would say, over in East Kent, which was actually mentioned by the Secretary of State yesterday. And my question to the panel is, in this move towards federated surgeries and companies, as Roy even mentioned, does this mean that one size has to fit all, that there's no space at all for the archetypal smaller practice, the Enid-centred practice that was mentioned yesterday by Helen?
Holly, you've written about the challenges of maintaining a traditional model of general practice.
I have indeed. I have experience of being in a small practice. We were unable to recruit and went through a very difficult couple of years, resulting in the decision to resign my list, which was one of the most difficult periods of my life. I've learned a lot from that, and I think if I'd been in that situation now, things would be different. I'm starting to see in the area working between practices. It was just too soon then for my neighbouring practices to see that they were able to help me, and they were under strain as well. So I think it's possible to exist as a small unit, but to work together as part of a bigger organisation, and certainly things like sharing staff, which is what we tried to do. We wanted to sort of parachute in a regular locum experienced doctor from a neighbouring practice rather than just booking ad hoc locums, which is what drowns you because that doesn't keep the practice running. So I think you can have both. We're in an interim point at the minute, and I hope it doesn't swing too far the other way where the individuality is lost and continuity for our patients. But I'm optimistic.
Arvind, it seems NHS England are pushing at-scale models of general practice pretty hard.
Well, I think there is a push towards at scale, but it's for a purpose that involves smaller practices and the resilience that a larger model can potentially provide. I was, back in 2007 in Tower Hamlets when there was 36 practices and 8 networks. Actually, the ability for collegiate working across groups of practices to support the smaller practices with the range of services they were able to offer was tangible in their survival through that period, and actually I would say that they're in a strong place now. So I think you can have the Whitstables and the fabulous work that's happening in that kind of model with all the ologies and all the access platforms and all the multidisciplinary teams and actually also be supporting the small practice down the road, because actually frankly our patients tell us that in many ways they prefer that, and we want to maintain the flavour of each individual practice. Nonetheless, it is true to say that we're losing about 2 practices per week, and the average list size of those practices is under 2,000. So if that's a choice on the part of a retiring doctor, so be it. If that's actually because they're finding it difficult and getting squeezed out of the system because they don't have that wraparound resilience, then that's something that we hope to achieve in the rollout of those sorts of neighbourhoods, primary care networks. We've got 12% of the country now covered by primary care home propositions. So actually this is a movement, but it's for a purpose that actually doesn't hopefully leave anyone behind.
Helen.
Just briefly, thank you, because it's a great question, Stephen. Definitely one size doesn't fit all, and I don't think one size will ever fit all for general practice, although it is a transition, I completely agree. For information as much as anything, our College Council debated models of primary care very recently, and we reaffirmed our full support for the partnership model of working as a very successful model that works very well. In fact, it's the only model that works in some parts of the country, but also fully support the recognition that in some parts of the country it's too late, and that other models work beautifully. So we have to work to the needs of the local population. So this has to be from the ground up. my own practice is merging it. So I'm a partner. I'm in a practice of just over 8,300 patients, and we're merging with the practice next door that happens to be in the same health centre, and we've always got on pretty well with them. But now that there's a generational shift going on, that I would say people of a certain generation are very happy to collaborate in a way that perhaps others haven't had to be in the past. And so the tide of change has forced us to have conversations, realise we're all exactly the same, we're great, we all get on, and it's making us, and actually merger's not easy, it's uncomfortable, it's rocky, it's gritty, but we're all learning from it. And, you know, hopefully this time next year I'll tell you what it feels like to be a post-merger. But it's not easy, but change is coming. I travel a lot and I see people all around the country, and many of the smaller practices, people say to me they're scared, they're afraid of being forced into something. And what I would say to them is, you are not being forced into anything. If it's working for you, great. My advice would be to get linked up in a federated way to other practices so you can share best practice, give you a bit of resilience and learn to trust one another, so that if something changes and you hit the sort of crisis that Holly hit, you have got resilience in your system, because that's the vulnerability of a small practice. If there are only one or two of you running a practice and one of you suddenly gets knocked over by a bus, then actually you are suddenly very vulnerable, or your one nurse goes off sick or has a crisis. And that's the stuff that's hitting us now. And in years gone by, it was no problem covering that, but without the staff and the money in the system, we haven't got resilience anymore, which is why we have to do other things. I'll stop there.
So a colleague of mine who's in a leadership position said you have to get big in order to be able to remain small.
Yes. Mm-hmm.
Roy, what do you think?
Look, I want to step right back off of this and think about not a conference of the Royal College of General Practitioners, but as a conference of small businesses, because that's effectively what this conference is. It's a conference of small businesses and the people who work in the small businesses. And looking at this as a business proposition, which is where I come from, I'd look at this and I'd say, okay, would I buy shares in this business? And the answer is I wouldn't. And the reason I wouldn't is not because I lack any admiration for primary care, because I think I've made that clear. And people who read what I write will know that I've made that clear. But looking at it purely objectively, you've got 2 practices a week closing. 2 a week closing. What does that tell you about this business? You can't carry your own insurance risk anymore. What does that tell you about the environment within which you're trading? You can't do the opening times. I get up in the morning and get on a train from Ascot into Waterloo. There are 2,000 people on the train. None of us have the opportunity to see the doctor before we go to work. And none of us have the opportunity to see the doctor when we come home in the evening, because even with extended working hours, it's closed. On a Saturday, it's there for an emergency, whatever that is. And on a Sunday, well, I go to church, sprinkle myself with holy water and pray for a cure, because you're not there. So for me and 2,000 other people on the train, primary care is irrelevant. And it's not the only train going into Waterloo. 250,000 people use Waterloo in the rush hour. For 250,000 people who live in the southeast, their GP, primary care is irrelevant. You can't cope with that. I'm not saying you're lazy, bone idle, you're not opening the hours you should, you're doing everything you can. The business model is screwed. I want to see a GP on Waterloo Station, and I want that GP to connect into my paperwork and notes if that's necessary. And I don't want to pay for it because I pay my taxes. I want an entirely different business model. This business model is screwed. Wake up, smell the coffee, think about what happens next.
Microphone.
Where's my applause?
I so want to reply to that.
Microphone 3.
Hi, I'm Shantaka. I'm a GP in Edinburgh, and it kind of question follows on very well from that. My question is, does the panel believe that general practice is still 24/7? And if it does, do GPs have a part to play in that? And if they do, is there anything we should do to recognise and support them?
Rabina, as a patient, do you want general practice to be 24/7?
That's a really powerful question. It's emotionally loaded, because patients will expect care to be 24/7. If they're in an emergency, if they're in need of help or reassurance, or if they're in pain, they want to be able to ring up somebody who's going to help them. Their first point of call will probably be the doctor, and they'll be connected to a service, out-of-hours service, and they'll be looked after by very competent and professional and caring locum doctors. So, in a nutshell, the expectation is yes. In reality, we know that in some areas it's becoming more and more challenging, it's becoming difficult. So the media reports that we see are that patients are queuing up and they're blocking beds within hospitals because they're in the emergency departments and they're there for many, many hours. So actually, for patients who are in need at their particular time when they're feeling vulnerable, they want to know that they are safe in somebody's hands. But I know it's been compromised at the moment for a whole range of different reasons.
Arvind, what is NHS England's policy on 24-hour care, out-of-hours care in general practice? I won't ask Roy that question.
Time to leave, Arvind. Taxi for Arvind.
So I'm not sure I accept the sort of premise of the question, in as much as I think general practice is 24 hours still, in as much as there is GP out of hours, which provides a wraparound service around the clock every day of the year. In my own organisation, I do 111 shifts. I can be found in the middle of the night in a car wandering around Bexley doing home visits on elderly people, trying to support them as best I can. So I think it's a question of what distribution of the workforce that we have we wish to put at which points in the week to respond to the need. And I think, many surgeries, the majority of surgeries, offer extended hours. So some of those folk coming back to the commuter belt in Surrey may have access to some of that edge of the day stuff. We have 17 million people who have extended evenings and weekends access in relation to the building off the platform of the General Practice Access Fund, with an aspiration to get 50% of the country covered by March next year and 100% of the country covered by March 19. And then we also are trying to bolster the offer that's within the 111 service, both online with pilots happening around the country, but also increasing the number of clinicians, including GPs, pharmacists, mental health therapists, dentists, within the primary healthcare team that sits within 111 and GP out-of-hours services, so that actually we can get to, ideally, a point where 50% of those calls are managed by a clinician and a higher proportion are closed than is currently the case. So I kind of think that we're sort of distributing the resources that we have as we try and build them and putting them in the places where we think they will have most impact.
So is it fair to say that policy is to let the thousand flowers bloom?
Well, I think policy is to try and clear up the front doors for patients, which are currently quite confusing. And actually, if we can get to a point where patients find it normal to ring 111 before, for example, going to an accident, an emergency, the sort of talk before you walk proposition, then actually there are ways that we can rewire how the population uses services, including general practice services, that actually I think would add to their convenience and add to our efficiency.
So Sian, you work in Scotland. How are things arranged in Scotland?
Okay, so I'm also National Chair of Out of Hours in Scotland, which I maybe should have said. In Scotland...
Interest should be declared.
In Scotland, we do have I would say, a flourishing out-of-hours service. It can be challenging to staff. We have 1 million patient contacts a year, and we have about 353 whole-time equivalent GPs who work in the out-of-hours service. I think it's really important that general practice is 24/7 for patients, and I would say that's what we're trying to achieve. I think the challenges in hours sort of make out-of-hours struggle, because I think GPs are so overworked in some situations it's difficult to commit to extended care.
Helen.
Thank you. That, Sian, fantastic. I love the unit. I came up and visited it and I was very impressed with what I saw, and I love the technology you've got and the quality of the IT you're using. Absolutely, general practice is 24/7, but the sort of general practice I talked about yesterday, patient-centred, Enid-shaped care, cannot be given 24/7. What we have to do is recognise that people, GPs, healthcare professionals, are not 24/7 people. I don't know about you, but I need my sleep. And I cannot be there 24/7 for Enid. What I can be is there in a regular time and place where Enid will know she can get me when we need a civilised chat, but that she will have somebody competent and qualified to see her when the acute crisis comes, who will have access to an up-to-date, accurate record at all times that they will feed into. So when I see Enid next, I'll know what's going on. And I do think that's very achievable. I do think that the issue about technology is going to make a big difference, so that when Roy turns up at Waterloo and wants his blood pressure checked, he doesn't care about seeing Dr. Helen or Dr. Arvind. He cares about having his blood pressure checked by somebody who's competent to do so. And that's a different sort of care. We can provide both those. Roy doesn't need Roy-shaped care for his blood pressure. He might like it, but he's going to have to sacrifice convenience, because right now he's relatively fit. He's a commuter. He's working full-time. He doesn't need that person-centred care in the same way that Enid needed it. And I think...
Roy, what does Roy-shaped care look like in this respect?
It's the fabulous Dr. Helen available 24. I can't wait to be ill. Fix me up, Doc.
Make an appointment, Roy, make an appointment.
Get in the queue.
Yeah.
Listen, I get all that. And of course, what you can't do, or what you've been bad at doing, is segmenting your market. If you sell frocks, you know that you go to Topshop and you get a certain type of person who buys their stuff in Topshop. If you go to Marks and Sparks, you know you'll get the near dead going in buying.
Check the label. I feel alive.
I know. This is not going so well. You segment your...
Sorry, put you off your...
God, you look gorgeous, darling. You just check my own label. Look, you can't segment your market. That's the mess that you're in, I think. I mean, certainly there will be people with long-term conditions and so on and so forth who will want that sort of long-term relationship with their clinician, which is increasingly more difficult because we've seen family practice disappear. And I get that. But for the people like me who don't want all that, we can, by looking after us differently, we can create the headroom for you to look after them better. And that's my message. And thank you. Keep clapping, don't worry, I'm just trying to think what I'm going to say next. I mean, this is all predicated, for people like me, it's all predicated on me going to you. Wake up, you've got to come to me. You've got to come to me on Waterloo Station. You've got to come to me someplace else. You've got to come to me on my mobile phone. You've got to come to me on FaceTime. You've got to do all those things that everybody else does in every sector of the market, in almost every other profession. But here we are, sitting in the 1960s, wondering why our businesses are going down the toilet. And it's, how are we going to do this? Well, out-of-hours care shouldn't be. Out-of-hours care should be run by hospitals, because the whole idea is to keep people out of hospital. So give the money to the secondary care, let them run out-of-hours care. Let's not, give them the money. Let them you don't want all that crap anyway.
Roy, you're losing your audience. Roy.
There's a lovely story about, there's an American comic called Will Hay, who was a slightly blue comedian, and once he did a show and somebody said to him, how did it go, Will? He said, it was terrific. The audience were with me all the way, but I shook them off at the station.
Holly, very quickly.
Joking aside, jokes are important, aren't they, for us? They help to pass the time of day. But I think...
I'm a serious academic.
I think it's about access and continuity, and we can do both, and we shouldn't be afraid of it. I think sometimes we hang on to continuity so much that we lose the opportunity to work in different ways. And I think the next generation will determine that. The young GPs that I work with are looking for a different way of working. They want flexibility, and I don't think that threatens continuity or, you know, the old-fashioned business, as you would say. We can have both, and maybe we can have them 24 hours a day. We've just got to work out who does what where, and we can choose which bits of it we want to engage with. But I think it's possible.
Thank you very much. Microphone 4.
Thank you very much. I was very grateful that Helen raised our college motto, Cum Scientia Caritas. About 18 months ago, I had the pleasure of meeting Dr. Perry Harrison, who actually wrote our motto and came up with our coat of arms in his home just north of Glasgow. And it was and it was just before he died, aged 100.
Wow.
There was absolute connection with us as far as what the core values meant, despite us being 50 years different. I'm also aware that we've just done a press statement this morning from RCGP Scotland about the huge support the patients have got for the core aspects of general practice to do with continuity, comprehensive care coordination, and so that is that positive message. So the question for the panel today is our motto still fit for purpose, and how do we live that in the future?
And Miles, your name is?
Miles Mack, Chair of RCGP Scotland and GP in the north of Scotland.
Helen.
Well, that's an easy one for me. I've already told you I love our motto, Cum Scientia Caritas, scientific knowledge applied with compassion. I think all that means for me is we start with the science and the evidence. Now, the evidence does not always have to be the gold standard RCT, beloved of the academic journals. And, you know, I've got an academic pedigree and I have the greatest of respect. And I want an RCT to tell me whether drug A is safe for me to take rather than drug B. But I don't need an RCT to tell me whether the way I get patients through the door of my surgery is the right way or the wrong way, because it'll take far too long, it's far too expensive, and it's not necessary. What I need to know is it effective, is it safe, and does it work for my population? So we need to use science in its broader sense. There's qualitative and quantitative elements to science. There's the learning from our colleagues. We should be auditing. We should be looking at quality improvement. Now, we've got the quality assurance side of things, which is what CQC does to make sure that we're safe to practice. And that's one thing. But what I believe in is quality improvement, giving us the headspace to innovate and do stuff, but keep evaluating it just to make sure that we're actually doing good stuff. Because as we all know, medicine is littered with stuff that's enthusiastically taken up and turns out to be just plain wrong. So, yes, science, 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 but then let's use it compassionately. Let's use it for ENID. Let's use it in the way that our patients need and want, not in a way that somebody prescribes from above should be the way to do it. Let's make it relevant to the patient. Otherwise, we're into over-medicalisation, over-treatment and over-diagnosis, which I would say is a great disservice. We could save ourselves so much if we have the courage to step beyond and start with the patient, not start with the science.
Rubina, from a patient perspective? Rubina, from a patient perspective,
yes,
does with science caring feel right?
Yes, I absolutely agree with what Helen's just said. And I think what's really important here and what we mustn't lose sight of is that although the caring and compassion is the end product, you get there through the science, because patients, when they come to you, need to know that they, as I said earlier, are safe in your hands. And that's because you are the experts of the clinical knowledge. But how you then demonstrate that through your professionalism and through your behaviour and through your value system is what the patient then reads from you. And there you have the outcome of the compassion. But actually coming together, it's about that partnership. And we need to enhance the spirits of the partnership and the co-design, the opportunity to co-design with patients and with carers about what that should look like and what it feels it looks like at the moment. And I think at the in the current time as we are now, and the other question around models of care and change, all of these things are emotionally driven, and we know, patients know, that you as GPs, you as our family doctors are affected, and you talk about the need to be resilient. I think that's a new word. I don't think patients recognise the word resilience or that system change requires resilience. What they need to know is what you've already said and what Helen has also reinforced, that science and knowledge is the partner to care and compassion. There isn't a gap between them, they're one and the same thing.
Thank you. Microphone 2.
I'm Jenny Aston, I'm an advanced nurse practitioner in Cambridge, but I'm also the college's nurse champion. How do we get politicians, including Jeremy Hunt, to see the importance of nurses in general practice. 5-year forward view has allocated a derisory £15 million for the whole of England to try and sort out the future of general practice nursing. So I'd value the panel's comments on how can we raise the profile of this dwindling group. Thank you.
50 minutes in and Jeremy Hunt's name appears. Arvind.
It's your boss, Arvind.
No, I work for NHS England. So I think you're right. I think we haven't given this the airtime, space, investment that actually it deserves, and we need to be continually looking at it. We have put £15 million into nurse development. There has been the recent release of the 10-point plan in relation to this space, and we do have a focus on return to work particularly, which was a drive that came from the college, particularly Maureen was very involved in that. And we do know that practice nurse numbers in terms of headcount and whole-time equivalent are edging upwards, but actually I think the reality is we need to do more. Now, one of the things that we have created around the general practice forward view, and to ensure it stays on track and we're scrutinising progress and we're ensuring we remain accountable, is an oversight committee of which the nurses form a key part from the Queen's Nursing Institute and the RCN, and equally on what's called the primary secondary care interface group between the acute sector and representatives from primary care. So I think we need to be doing more, and it remains a focus, and I think that's probably one of the things that we're 18 months through the general practice forward view, and we've achieved some things. There's a lot more to do, and I think this is on that list.
Jenny, do you think that practice nurses have lost out as a consequence of the growth of the other primary care health professionals?
Definitely. I think the emphasis on new roles such as PAs and clinical pharmacist and your emergency care practitioner, all of whom are absolutely vital. We need more of everything to survive in general practice. But I do think the essence of nursing, which is part of good care for particularly long-term conditions and for health prevention, is essential. And I think you do need to value the core team of nurses and healthcare assistants in general practice. Otherwise, it will fall over.
And are you confident that NHS England's 10-point plan for practice nursing will make a difference?
No.
Would anybody else like to comment on this on the panel?
Yeah, I would. Look, the only people that I know that downplay nurses are nurses. I think nurses occupy a central role in people's thinking about the NHS, about the interfaces they have with the NHS. Nurses are, I don't know how else to say. They're pivotal in the delivery of healthcare, and it's only nurses that downplay nurses. And I have to say this to you. You have to understand the environment within which your business activity takes place. We, as a nation, are skint. There is no money. And when you say we've been given a derisory million or whatever it is, it's all there is. Now, you can argue the politics. You can say we shouldn't have austerity politics and there's loads of other ways of doing things. You're right. And you could say, well, we shouldn't have voted to come out of the European Union and that's screwing up the economy, and you're right. But we are where we are. And it's no good moaning about the money because there isn't going to be any more money. Get over it. Get on and run your businesses with what you've got.
Helen.
I'm not going to argue with Roy for a change. Actually, Jenny, your point was brilliantly made. The 10-point plan, I was very disappointed in the 10-point plan. We'd had high hopes for it. The college had been involved. And then when we saw it towards the end, we put our foot down and said, we can't sign this. It's not strong enough. The intent was good, but it didn't have the hard outcomes that we're seeking. What it has got now is a promise to have some hard outcomes put in it within 6 months' time. And we are working very closely to ensure that exactly what you said is fulfilled, that it is clear, it is better, But there is something about us all taking responsibility as practitioners for our nurses. I think historically we haven't valued the professional development of our nurses enough. In our own practice, we took a big risk about 10 years ago, and we took on a newly qualified nurse and paid for her to train up in general practice nursing. Worked brilliantly, actually, but it was a big gamble, and other practices around us looked at us in complete horror. Surely what you do in general practice is take very mature nurses who, 20, 30 years experience, and they want to change and a bit more flexibility and work closer to home. Well, actually, no, we need to think more creatively. Now, so I think historically there's a culture in general practice about paying for our staff and training them and nurturing them that we need to think differently about. So that's one thing. The return to nursing programme is a great idea. We're still not sure how many nurses there are out there that we can lure back in, but we should certainly go looking for them. And so the big thing is keeping working closely with NHS England, Health Education England, to ensure that what we get is what's right for general practice and what we need from the grassroots, not what somebody somewhere thinks on paper looks like a good idea. So it's getting that voice through, but we are working closely with them, and I'm very much appreciative of your input at so many levels to make sure that voice is heard, Jenny, so thank you.
Thank you very much. I'm sorry that we only have time for one more question. Apologies to those of you who've been queuing patiently. I'm going to take microphone 1.
Janet Massey from Felixstowe. In Felixstowe, we have a very good community hospital, staffed with very good nurses as well, who deal with chronic conditions, especially lymphedema and varicose ulcers. I don't think that Roy's robots are ever going to be able to put on these sorts of things, or in fact there will be a way of doing it which won't involve nurses. I wonder how the panel regard community hospitals generally. Thank you.
Can I just say, I am the Vice President of the Community Hospitals Association. And I never mentioned robots, he did. So if you want to ask another question, feel free.
The question was about community hospitals, Roy.
They're fantastic. We need more of them. Give them a round of applause.
Yay!
Hey!
Helen.
I love community hospitals. I've got one in my own locality. The hardest thing is about 4 years ago, the GPs lost the right to admit to the community hospital. And that was just... such a heart-sink moment, But anyway, I mustn't bring this personal. Absolutely, community hospitals can be fantastic so long as they're used appropriately. They're not necessarily a cheap way of delivering care, but they can be a very patient-centred way of delivering care, which can turn out to be better in the round. It isn't necessarily better for the CCG's funds, and that's where the challenges come in, and that's where we've got to work together. I'm hoping the STP level approach will allow a larger scale approach at looking at these things, which is bigger than CCG's, and we'll see them come back into fashion. It'll go around the circle again, as it usually does.
Arvind, the localism agenda in some ways is putting community hospitals at threat, whereas you hope it would do the opposite. Where are you on community hospitals?
Well, I'm in the same place as I am on actually the sort of redesign of all services out of hospital, which, I think is actually we need to be trending towards a blueprint that learns from the best of what's happening around the country and actually go out with a bit of a vision on this that is broad enough to allow those who are pioneering not to feel constrained, but gives enough scaffolding for those who are feeling lost on where to start. And it's actually, how do you layer in the services that sit in the community, and how do you actually start to kickstart, in a sense, the reinvestment cycle that might be data-driven, where you're bringing colleagues together in groups that may be 30 to 50,000. We don't need to be prescriptive about that either. That actually changes clinical behaviour, and it might be across prescribing, elective or urgent care, that creates headroom for reinvestment in the continued and acceleration of that layering of services within the community that feels like a neighbourhood to that set of practices at that sort of hub and spoke platformish level. So I think the business cases for each of those need to be examined individually to work out where they stack up in relation to the acute sector, and we also need obviously to make that a soft landing for how we resculpt what's done in a hospital, what's done in a mental health trust, what's done in a... And actually the sort of workforce challenges around that and the broadening of the strength and strengthening of the primary healthcare team are all key ingredients to getting there.
Thank you very much indeed. One final question for the whole panel to answer. What one thing would you do to reintroduce a sense of joy and a sense of privilege in being a GP? One thing. Holly.
I would focus on curiosity, because I think curiosity is what made me want to be a GP. And I think the next generation need to be invigorated and they need to be curious.
Thank you. Rubina.
I'd get rid of the Daily Mail, but that's another story.
That will probably do, actually. That's fine. No, please, do finish.
I think it's really important that you feel valued as a profession, that you feel valued as individuals in your own right. I know that some of you have already said GPs are patients too. Your well-being is important. You need to feel loved. And I think just generate a persona of a community of general practice. I myself don't see you as a community of small businesses. I think you deliver public benefits and that's important. So joy should be feel good about yourself and be proud of who you are.
And write your own narrative, as you described. Arvind.
I think we need to declutter the consultation and actually move away or rebalance that sort of competing interest of do I fill in the alerts on the screen or am I listening to the patient in front of me? And I think the sort of move away from micro incentives and getting away from the situation which is currently the case that I think too many people are feeling resentful at not being able to deliver the kind of care our patients need and the kind of care we want to deliver.
Thank you. Roy.
There's only one person who can affect your morale, and you look at them every day in the mirror. Be proud of what you do. You're doing a great job, and thank you.
Helen.
I would love to give every GP in the country the space to give Enid-shaped care, and that'll make us feel great about ourselves again.
Great. Thank you very much indeed. So I'd like to thank all the panel who I think have been stunning given that they had no preparation for any of the questions. So thank you so much to the panel. Thank you to the questioners who have asked a great range of questions. Thank you so much. Thank you to the audience. You've been absolutely brilliant. And we now have a coffee break for an hour. Thank you.
We survived. Well done.